is Claire Wallace with Becker's Healthcare. Thank you so much for joining today's webinar, AI and RCM, What Healthcare Leaders Should Know. With that, I'm so pleased to introduce today's speakers, Jonathan Wick, Michael Wallach, and Pinaki Gaushray. Thank you, John, Michael, and Pinaki for being here today, and I'll go ahead and turn the floor over to you to get us started.
Thank you, Claire. Thank you first and foremost to Pinaki and Michael for joining me. Welcome to my world. I think I'm on a webinar at least once a week or every other week, and so excited to talk about what we're about to talk about today. We're going to dive right in if that's okay. So really want to just define AI for you today. I am not the AI expert. That's Mr. Wallach there. He'll get into it in a little bit of his section, but I remember the days when I was in revenue cycle, and Pinaki remembers this too, I bet, where you heard these two letters and you immediately replaced them with the letters BS. And you were like, what does AI really mean? Like, you got to talk about whether it's RPA, whether it's machine learning, what are the use cases, and where are we at? And I like this diagram. Finthroy put this together to talk about this broader category. Think of AI almost as a library. And then you've got to check out these books within it, or a website, if you will, and you have to go to these different tabs within it. And as you enter tabs and go into different windows, it gets more and more finite with the level of functionality. I would argue this Venn diagram also has some interdependencies as well. You can't have natural language processing without machine learning, for example. And a lot of it's going to be foundational on those data sets that are there to start your journey. And we are on an AI journey. I think it's starting to finally get a lot of momentum in healthcare. It's been around for decades, but I'm starting to see, especially on the finance side, it got a little bit more of a bump on the clinical side for obvious reasons, but we're seeing use cases, and Pinaki and I are going to walk through those with you today, just in terms of billing and patient access and some of the analytics and things that are there, and really help define what it is that we're doing in this space. AI can make up funny stuff. Are these chihuahuas or are these muffins? It doesn't know the difference. And you have to know the knucklehead things that it is. It's a computer. It's going to take inputs and create assumptions. It's getting better at it. But as you're listening to Michael and Pinaki today, and I want you to think about the application and make sure that you've got validation and monitoring and those types of things in place as well. Because I think the genie's out of the bottle. I was at HIMSS a couple weeks ago, and it's exciting and it's also terrifying at the same time. You've got to really harness this in a way that makes sense to where your teams understand what it's doing for you, and also some of the dangers and risks that are there. We don't have a lot of talk today about governance, but that's something I think we'll probably do in some sessions down the road, to talk to hospital systems like Pinaki's and get some perspectives from Michael, who's been doing this for a while, in terms of what organizations are doing to manage this. Like, what does that look like from a committee standpoint? How are they, are there policies in place that says when you can and cannot use it? How much of it can you use? Is it exclusively used? What are your copyright and your use permissions that are out there? Those types of things are all considerations as you go on this journey. Let's talk about healthcare for a minute. Journal of American Medicine, one of my favorite articles, it's getting a little bit dated now, but I really love it because it has these kind of stratifications like clay that are talking about waste. And they said there's about $800 billion of waste. Congress, interestingly enough, just passed a bill in the House and the Senate that's going to get reconciled that wants to cut $880 billion of waste out of healthcare. That number's darn close. I know it's off by 80 billion to this one, and this is an older study, so maybe it's amortized up. So as much as you think about Washington, D.C., I think they did a little bit of their homework. The layers, I'm not going to get into a super huge amount of detail here. You guys will get a copy of this deck, but talks about failure of care delivery, coordination, low value care. The stuff in blue really is, the art and science of medicine, I like to call it. The stuff that's in orange really are the administrative part. We're going to talk about that today in quite granular detail. And at least JAMA feels, and they did the study with Humana, if I recall, in a joint effort, a lot of that administrative complexity can disappear. Now, the only thing I don't agree with in here is they've absolutely eliminated it, right? It's gone. I don't know that AI is going to do that, but it absolutely should make things more simple for your organization. You're still going to have levels of fraud and abuse. I would argue a little bit of waste. Things are still not going to be quite priced appropriately, but the administrative benefits that come out of automating intelligently through AI, especially in your revenue cycle, are going to be apparent. I'm not just saying this either. This is a survey from Acasa, and they're saying, hey, how do you enhance your revenue management? What do you do in your revenue cycle? And they had, kind of a pretty, equal or equitable pizza here, I would call it. Find a strategic partner. That could be a FinThrive, right? Adopt new technology. We're going to talk about that today. Eliminate redundant systems. You'll hear FinThrive talking about the power of the platform, the platform effect, reducing that redundancy. There's a security influence there as well. The more nodes that you have out there, the more risk and exposure you have. Most hospitals I talk to have 25 to 30 systems. Pinocchio, I think, at north of 60, and he's got a goal. He's gotten that down quite a bit. He's got a goal to get that down into the tens or high teens this year at Prime. And what I love about this slide is that almost all of those solutions surround tech and finding a partner, about 80% of them. And we're going to talk in a lot of detail today about that. Artificial intelligence, per this study from McKinsey, has a $360 billion, with a B, dollar influence or possibility to organizations. Excellent study from McKinsey. Happy to pass it along after this talk. Talks through specific use cases that I've highlighted there in green: encoding, prior auth, denials management, CDI, and super huge, super important application. Analytics, another area which I think is lacking within revenue cycle. We all have Slicer, Dicer, and Epic if we're using that. We might be using ClickView or Power BI, other tools. Those, frankly, can't connect some of the modularity and some of the insights that can happen from an eligibility response as it relates to the loading of a bill, as it relates to those dollars being posted and the insurance follow-up and some of the denials and underpayments that are happening. Very, very important to have that. 750 hours of RCM's time annually can be saved by looking in the right places instead of spinning wheels. I've talked enough. I'm going to give you to someone way smarter than I am, Mr. Pranaki Ghosh from Prime Healthcare. He's going to walk through who Prime is. If you haven't heard of him, I'm sure you have, but if you hadn't, and then he's going to share some things that are going on there, and then him and I are going to kind of tag team on the RCM stuff. Pranaki, thanks for being here today.
Thanks, Jonathan. Good morning and good afternoon to all of you in different parts of it. Disclaimers, couple of disclaimers. I definitely don't profess that I'm smarter than Jonathan. He rhymes with John Wick, and you can understand why I do not want to be smarter than him. The second thought is really around the fact that the next few minutes that I'll take from your conversation, we don't claim to be super users of AI right now, right? We are in a space of cognitive era where this is one of the tools that is out there in the market, which we have to absolutely understand a ton better. A lot of people are getting to understand this a little bit more than others, and we want to stay ahead of the curve as much as we can. Some part of my conversation, as I inform you about Prime Healthcare, is going to be poignant about who Prime Healthcare is, what we are doing in a specific use case around AI. And then I will partner with John to sort of help you understand what else is going on from a general perspective. What are my fraternity of other providers doing or trying to sort of get into the space of AI that we talk about it. Who are we? What is Prime Healthcare? Prime Healthcare, and I'm passionate about where I work. I'm passionate about what this company stands for. And as you can see from a slide about Prime, and I've been here for the last good part of the decade, is really around saving hospitals, saving jobs, and saving lives. So that's primarily who we are from a Prime Healthcare perspective. You can read through the missions and the values aspect of it. I'm not going to regurgitate it, but the real value that we add as a provider network is to our patients, is to the communities that we serve, And the differentiator that Prime brings to the table is we are physician-led. John, if you want to just slide down. The aspect of being led by the physician shows up in our ability to sort of get the recognition from the market and our peers from a perspective of the multiple different aspects that we get recognized on. State of California has recognized us, and we are the second most recognized from a general perspective. The 7 hospitals, as far as patient safety excellence awards are involved. We are obviously a top health system from a Fortune perspective. We are in the 100 top hospitals. Multiple of our hospitals are in there. And Healthgrades has been generous about our ability to perform clinically as well. If we move to the following slides, this just goes to show where we are at. We are across 15 different states in the United States and about 50 plus hospitals, which the following slide is going to really walk you through. We are also broken up between 2 parts from a general perspective of foundation hospitals and also for-profit hospitals. So that's something unique about Prime Healthcare, allows us to sort of be in the markets where it's more attuned to serving the communities, and there are obviously aspects around for-profit. If you go to the core of our conversation, hopefully we talked enough about Prime Healthcare, and I'm open to sort of take questions towards later part of it. From a standpoint of our overall strategy, and AI definitely features in it, we have definitely delved more around ensuring that our physician-founded and led organization runs in that same model of acquiring any new hospitals from a perspective of driving the standardized work across anything that we bring in. Obviously, that goes from a clinical aspect of it, also goes into the revenue cycle standpoint of it, and into anything that we are doing from an overall artificial intelligence perspective. So running to the core of it, what we have done, and we'll use a specific example over here, is really our investments into technology and specifically into artificial intelligence. One example of it is our partnership with Steer Health. That's something that has happened for the last 2 years now. We have launched in partnership with Steer Health a platform which is called Get Care Now, which is designed to address any new and evolving healthcare needs for our customers. What does it do? It focuses on creating easy and convenient, affordable patient care, which is really more patient-centric. And our strategy is to utilize state-of-the-art technology to improve our access of care, enabling real-time feedback on patient experience. The specific aspect around artificial intelligence really gets into the core of it, where we start looking at care now, where the patients can actually start communicating with us. And that's where our journey to support the patient's consumer experience gets into the aspect of artificial intelligence-enabled conversational texting, live customer navigation, and patient-centered 24/7 virtual care. So the strategic aim of Get Care Now, in addition to getting better health outcomes and a lower cost of care, is to ensure patients feel known and valued, and whenever they engage with our Prime Healthcare network. With that being said, I think over here, which we can talk about, obviously covered most of it. Licensed beds perspective, you can see it's more than 10,000 plus licensed beds. We're serving across 600 plus communities. We have written off 14 plus billion from our charitable contributions. And we definitely, whenever we are acquiring any new entities, we put in capital investments to ensure the community and the patients are served better.
Cool. Well, thanks, Pinaki. That's awesome. Prime's a behemoth out in the West. I think I appreciate the not-for-profit, for-profit hybrid there. That's pretty unique. The investments are there. Pinaki and I are going to tag team on this next section here and really talk about AI and revenue cycle specifically. We're going to go deep into some use cases, not super deep, but just kind of bounce back and forth and banter a little bit as we're walking through these next sets of slides. These are challenges that I'm sure everybody on the call has seen. I had, 15 to 20% turnover at my hospital. Pinocchio, probably better leader than I was. I think that's just the nature of the business too, especially in those entry level roles. There's been a lot more, I would argue, compression in terms of price banding or average hourly rate banding in most communities now. Healthcare used to be one of the more probably favorable employers to work for. And as fast food and retail and some of the other markets came up, we compete for those now, and that results in turnover. And cash is something that's always stuck. It's never moving as quickly as we would like in our organizations. And claim edits certainly are something that I think everyone measures in touches that I talk to, and understanding where those ICD-10s and DCNs and CARC and RARC codes and posts and lock boxes and all of those touches happen. And automation can help with all of those things. I think we outsource some of this. We handle it in-house. We try to do what we can as an organization as we move forward. These are use cases across the organizations that Clarivate or HBI measures. What I found impressive is this is kind of like a nice piece of art. There's not really any one big case that folks are using it in. That big pocket there was payment posting, that second tranche, the one there in the middle, insurance verification, that makes sense. And as you get over to the right, you start seeing some things in posting cash as well. There's a large swath of use cases as you're moving across. This is just another laundry list of different things that we're using AI for, things that we encounter with our customers that Prime is using as well across eligibility workflows. I think eligibility and claims represent large areas of automation opportunity. That certainly are the two, I would argue, cargo ships that pass into the port of revenue cycle more than anything else, is eligibility and claims. Pinocchio, do you see or have ideas about automation opportunities at Prime that fall inside or out of this list? Or are there some things that you want to highlight that we go through in the next slides that are there? Are you still kind of embarking on this journey, as you mentioned?
So as I said, I think from a general perspective, us as a network are evaluating multiple different options within this aspect, right? In general, when I'm generally talking from a larger swath of provider network friends that we have, when we're talking about it, most of these things, if not all of them, are being targeted and sort of reviewed at. I'll hit on one specific area, which is really around the fact that if you look at the challenges around the insurance found avenue, right? So you have aspects around insurance verification that is going on. It's going to be completely contingent on how our staff, any staff from a patient access perspective, goes in there and starts reviewing it and then goes back and sort of updates it. You would lead into situations where they're doing some kind of quick reg, somebody's coming back and catching up later, and so on and so forth. Having opportunities for AI, which is coming in, and ability to sort of update information on cue, especially when you don't have a laundry list of payers, which is infinite. We have a finite number of payers that are out there from a patient's perspective, especially if you know you're in a specific neighborhood, you would know exactly what's out there. So leveraging AI becomes a lot more opportune from a general perspective in that specific area. But then again, it doesn't cut out the other items over here as well. Back to you, John.
Thank you, sir. I like saying it's your revenue, go get it. It's your chance. You could do things for free as an organization, and you heard about the billions of dollars that Prime donates back to its community. I think if Prime had the choice, it would have preferred to have had some sort of funding mechanism than having a write-off. That's how most hospitals are. You absolutely are there as an asset, as a steward to the community, but it's best to be paid for the services that you provide. It's a non-sustainable model over time to have 100% charity care. And in the survey, in the hospitals I talk to and just survey in a straw poll manner, there are all kinds of levels of opportunity in terms of automating and looking at where things are at. Value drivers for this are the big three. Where is the problem, and is there low-hanging fruit, or sometimes I like to call it high-hanging fruit, where there's some things where you're getting from good to better to best? How much time are you saving? And then is this scalable? I've seen lots of things bounce off the atmosphere as folks are doing this automation, and they're not applying it in a way that is changing or moving the needle within their revenue cycle. Pinocchio and I are going to walk through 3 or 4 of these. We'll see how we're doing on time. As I mentioned, you'll get the slide deck here. But these are foundational, I would call blocking and tackling type processes that occur within most revenue cycles. Michael has a couple examples of some of the innovations that we're doing. So stick around towards the end of this, where he's getting at some denial workflows and appeal workflows that are there, and also understanding just contract management and what that looks like, which really kind of drives a lot of these other things. We're talking about the front end right now. These are 4 major processes that every organization pretty much has to do to get financial clearance on the front end from their intake standpoint. Eligibility, obviously. Do you or do you not have insurance? Do you have multiple insurance? What's primacy? Insurance discovery is being used there quite a bit. The MBI lookup is still very real. Are you looking at the identification number and be able to match that up to the cards that are in front of you? And then are there information request letters? Do you have coordination of benefit issues? The notice of admission, the NOA, the consents, those types of things are all things that can absolutely drive challenges in time and automation in your organization. Are there things in patient access that Prime is looking at, Pinocchio, that fall into this or maybe another category?
So I think we're using, as you had covered in some of these aspects of it, right? So having information around a person's presumptive eligibility aspects of it, that's something that we're definitely looking at. Looking at avenues of keeping on improving our insurance discovery process, that's integral at any point of time, right? As in, I don't need to profess how much a differentiator is from a person or a claim if you are a self-pay claim versus you actually have an insurance aspect of it. So that's also there. The world around prior authorization is also evolving, and we have to keep evolving with it. So that's a constant moving towards the goalpost kind of a situation.
Great. Back to the back end here. Pre-billing scrubs, I think, is pretty common in the market. Late charge management, the OR used to drive me up the freaking wall, for lack of a better word, with our implants, our stents, any of our implantables, some of the infusion drugs. We had them built in purchasing. We paid for the dang thing, but we did not have the exact invoice and the J code or the C codes attached. And that really jacked up, for lack of a better word, our DNFB. And there's a ton of AI out there that can match things based off the surgeon, the people in the OR theater, the patient that's there, their age, those types of things to help create a checklist and things that are there. Populations on type XX7 bills and claims allows bills to get charged better with an independent claim number. A resolution of claim edits as well within the work queues. And from the people I've talked to in Epic, they're kind of sick and tired of work queues. There's too many work queues right now. They're trying to consolidate those down. Again, big benefits here in terms of wasted time, staff focus, reduced billing costs, expedited in cash, those types of things. Pinocchio, thoughts on the back end?
I think there's a lot to be done in the general perspective from a scope of what AI can come back and do for us. I'm extremely hopeful around more items coming on board, but it's too early to call it right now.
More stuff from the billing office. Third-party liability is a big deal. Faxing to Medicare, which I believe they still do. I was just out at a conference where Revenue Cycle Conference out in San Antonio, and they were talking about how they asked the room, how many people still fax? And everybody raised their hand. And then they said, is it less than 10% of your business? And almost all the hands came down except for a couple, which is great. So that tells you there's still paper going back and forth between hospitals and I would argue payment vendors or post-acute care, those types of things, and the payer. If that's happening, that absolutely is something you should talk to FinThrive about from a document management standpoint. There shouldn't be fax machines that exist anymore, to be frank, and there's ways to make that an electronic submission, and also just from a record and indexing standpoint, there's companies that we partner with and others that help make that process just a lot more efficient. The same goes for the Fujitsu scanners that exist on the front end. We didn't talk about those, but there's just ways to kind of remove that manual step, and it's also just more accurate. I'll skip on down since you already talked about the back end a little bit, Pinaki. We'll get into cash. Let's talk about accounts receivable and really claims workflows more in the back, but EHR workflow integration from claim statusing, leveraging that 276, 277 transaction, managing those 835s as they're coming back as you send out your claims, or you're matching them up with the ERA, the EFTs, the remittances. Those medical record denial solutions, one of my favorite use cases for AI, specifically RPA, is to put a claims hold on all payers that require medical documentation attachments with the claim. Go into HIM, go script that, pull out the associated SOAP note, H&P, discharge summaries, write the letter, put it on top of the claim, then send the whole package out instead of playing tennis and it's 40 love 3 weeks down the road. You might make your DNFB go fat for 72, 96 hours, but you're going to save yourself a week of time down the road by automating that up front. And there's some very payer-specific rules that impact that. And then we talked about patient request letters, but are there things in the cash realm, Pinaki, that come to mind, or are you still kind of dipping your toe in the water here as well?
This is we're dipping the toe arena. This is cash, right? You can't mess with that.
That's all right. No worries. These are some examples of some use cases that FinThrive has as well, delivering out-of-the-box intelligent automation, and I love that term, but we've measured it in terms of FTEs and ROI. And I think as you're evaluating technology, be it from FinThrive or anybody else, and I know Pinaki does this as well, you absolutely should at least get what's in those green ovals: known, defined, set as a goal, monitored, reported back on, and adjusted as you go forward. I think if you're using automation, intelligent automation, any form of AI, be it machine learning, RPA, some of the Gen AI that Michael's going to talk about, it should make you better. It shouldn't make you worse. And what is better? And keep it that simple. How are we measuring better? We didn't have this before, and we seem to be doing okay. If we have it now, what is the delta? What is the incremental improvement that we're doing better? And there's some use cases here that walk through that. Simple things like my team was able to touch 12 more claims a day. Great. The next time there's a position open, if your productivity benchmark is 60 claims a day, and you put this in 5 different claim workflows, you may not have to fill that person, so you saved an FTE in terms of claims follow-up touches because you've automated that workflow through RPA. It can help to optimize when used properly. And Pinaki, I'm going to lean on here a little bit because I know that you've seen things go bad in your career. It can drive tremendous cost savings. We've shown you that today. It absolutely can maximize your workflows, and it can make manual repetitive tasks go away. But it's important to have an enterprise level mindset. Prime is a very large, 51 facility organization, almost nationwide, coast to coast for sure, and has not deployed AI in a way that you would think in terms of the size of the organization, and that's intentional. Can you double click on that for me, Pinaki, and help me understand, like, you guys are very critical of the tech that's coming into your organization, and why is that?
So a few things that come to mind, right? So from a general perspective, we have to be absolutely sure about what we are bringing into our organization. Second of it is really from a prioritization perspective. Our core competency is clinical, right? We stand out from a clinical perspective, and we want to make sure that anything that we are bringing in absolutely resonates that same physician-led environment about saving lives, saving jobs, and saving hospitals. So as we go through this new rush to deploy AI all across the board, we are being very diligent about what we should be looking at, what we should be identifying and running with it. As much as all of us on the phone who are probably also utilizing some shape or form, you're using RPA, right? So please make sure that RPA is separate, AI is separate, right? So RPA, absolutely everybody's using it. AI is more coming in from a general perspective of Gen AI and others. So the way that we are thinking through it is we are being deliberate about making sure that there is no hallucinations led in items that come through and sort of mess with your overall operations. And that's part of the reason we are being deliberate about where we are implementing it or will implement it and making sure we are staying on top of it.
Excellent. Excellent. If you take anything, like take that 60 seconds that Pinaki just said and apply that at your organization, because I think that's huge to understand. One, everything's centered on the patient, where you're at. And then, yeah, let's buttress that with the other things that we need to do in finance to make that frictionless and touchless where we can. We're going to focus it there. I like this. If there's any Flavor Flav fans in the audience, I had to throw him out there. I actually saw him in Vegas a couple of years ago. He showed up with Flo Rida. Don't believe the hype. Digital Underground. Don't believe the hype with a lot of these things. Dovetailing off of what Pinaki had said, AI absolutely isn't a set it and forget it. You have to have monitoring, reporting. I heard Pinaki say the diligence word too. Make sure that you're reticent about not having hallucinations disrupt your operations. There's this fear that it's going to replace humans. And Jeff Woods is a person that spoke to Pinaki and I at a conference we were at a couple weeks ago. He said something that I think we've all heard, but I'll repeat it just for folks that may not have. AI is not going to replace humans, but it's absolutely going to replace AI. People that know how to use AI are going to replace humans that don't. So it's an upskill. It is not something to ignore, gang. I think Pinaki and I and Michael are going to really hit that home in the summary. This is not something you can say, yeah, that's neat. I'm going to wait for everybody else to kind of figure it out over the next 3 to 5 years. You'll never catch up. AI is going at such an astronomical pace. The generative AI things that are happening, the deep seek modules that are out there, and I'll let Michael kind of get into the details. The tech, frankly, is going at a speed that is absolutely skyrocketing. Emotion, I've actually dealt with AI quite frequently, and you can build emotion into it. I think it's there. There's this level that you can't trust it. And you heard Pinaki talk about hallucinations and making sure, and having validators or bots for the bots, I think is important. That removes some of the fragility or brittleness of it. You can't automate everything. Prime's an example of that. Prime doesn't have a huge level of penetration of AI at their organization on the finance side, but as a physician-led organization, they absolutely are putting it in the clinical side, starting there, figuring out what can and can't be automated, building a lot of those policies and procedures in place to kind of understand. And then I'll skip down to, the enemy of good is perfect, right? I think you got to start small. I'm a lean guy. That incremental improvement of moving that ball up the ramp and sliding that wedge underneath it over time incrementally is huge. Do you have any hype or other insights on this slide, Pinaki, or you want me to boogie to the next one? Or okay, we'll go to the next one. I think you're still on mute. Didn't hear you. Big Yoda fan too. This is a checklist. I'm not going to get into a super huge amount of detail with these things, but you can't kind of do AI. You either need to do it or not. And I don't know that you need to deploy it holistically across your whole organization. You just saw from Prime that that's a great example of where they're really double clicking on the clinical side and understanding their patient-centered care workflows, their physician workflows, then their Epic environments, their instances of Epic, and really standardizing there. Then they'll expand into some of the things that we talked about in the front, middle, and AR areas of revenue cycle. Stability is one I'll focus on. The third one down, you do not want a volatile process. That's gasoline on a bonfire, I like to call it. If you've got a bonfire, you need to put the fire out before you start trying to make it better. AI is an accelerant. It absolutely is an accelerant to things. You want to make a good process better, not a bad one worse, if that makes sense. And can you measure it? We talked about that, especially in terms of hours or dollars or maybe turnaround time or just, frankly, just throughput. Pinaki and I are going to be quiet for a little bit, and we're going to let Michael talk about what FinThrive's up to from a AI standpoint. Michael, lay it on us. Thank you for coming.
Oh, yeah, thanks a lot. I appreciate it. Yeah, so I don't think anyone would be surprised that AI adoption and investment across healthcare is increasing because it's growing everywhere. Clinical use has been at the forefront, but RCM use cases are evolving. We'll see significant investment in the next few years. That's true at FinThrive too. where we're focusing on those that reduce costs, increase our customers' revenue, and streamline their work. So on the next slide, I'll talk about our AI evolution at FinThrive. This one's a little different. Okay, today we have actually over 50 use cases for AI to prioritize and work through. This slide lists a few of them. And we started by developing machine learning models that predict key metrics like cash flow and identify claims that are most likely to be paid. And then we started clustering denials and underpayments so that they could be appealed in bulk. The next step in our evolution was we started using document intelligence to extract data from photos of insurance cards and licenses, and improving accuracy and efficiency for our patients. And that was great. So when LLMs and Gen AI arrived, we formed a cross-functional team that meets regularly to discuss AI initiatives, progress, new technologies, ideas. Oh, and I should mention that we're starting a client group as well, focusing on AI and security, and we welcome anyone that wants to participate. A community like that can help you get started with your internal best practice groups. One of our group decisions was to roll out Gen AI tools for every colleague to use, whether they're developers or customer service reps. And this helped our organization understand what AI is capable of. And it's generated ideas from every group in the company. So that's how we got a lot of our use cases. Everybody's thinking AI first and they understand what it can do, and our use cases are piling up. The next slide has a few more of them. We've been building ML models for years and have a strong data platform that helps us move fast, but you don't need all that to get started. Generative AI can offer you quick wins with much less infrastructure. You could start with a use case that doesn't require like a major workflow change at your organization, so you can pilot it easily and then show some value early. And I'll run through how we got started. Like our first Gen AI win was in prior authorization. We used a large language model to read payer policies and generate rules that were previously entered manually. Now we're automating that policy monitoring and injecting rules directly into our Auth Manager app. And our first chatbot was built for our internal support reps so they can quickly find solutions for customers' questions or problems. And next, AI was used to auto reply to patient messages in our Access Coordinator bot. So you could say that is speaking back to a patient, but it's filtered through. And if it can't answer the question, it ends up in the inbox of our end users. But this reduces the inbox clutter so staff can focus on high-value interactions. And I just want to point out that this is an example of AI isn't about replacing people. It's about letting people focus on higher value work. So it's not to be feared. It takes a long time to develop these processes one by one. And you could say almost everybody's job could be replaced by AI, but there's so much work involved, and it's quite expensive, as you find, so that you're safe for a little while. Soon we'll offer a chatbot in our analytics tools, and this kind of kicks off a series of projects. We're allowing customers to chat with their data. And we're making insights more accessible, whether it be around claims, payer trends, financials, or any other aspect of your business. We're at the point now where we can start putting all these types of tools together, as we'll see on the next slide. Yeah, so there's a good example. It's an example of integrating these tools using agentic AI. It looks complicated, I know, but depending on your environment, it may be orchestrated within a single tool. In the first step, we've got tons of denial appeals with known outcomes, so we're training a model to suggest the appeal strategy that's most likely to work. And we based on what's worked in the past, So next, agentic AI has a lot of different definitions. I know we hear that all the time, but here we're just using it to execute a set of tasks based on the suggested strategy. So in this example here, we have a medical necessity. And in first part of that strategy is we need to retrieve the medical record from an EMR or EHR, and we use RPA. Then we can generate an appeals letter justifying why it's necessary, and that's something that we can improve as we go on, tackling different types of codes and different types of cases. And lastly, we can use RPA to appeal the denial with that generated letter in the payer portal. But we can also use voice RPA to call the payer, and the same can be used to check the denial status too. And a feedback loop is important to improve the process. Each appeals result will help us revise our machine learning model, to update the strategies, and improve the letter generation, all that stuff. Okay, so here is another example. And I figured people are wondering, where do I start? I know I put a lot together on that last slide and it was pretty fast, but basically you pick one problem, something that's repetitive, high volume, and annoying, and that's your best candidate for AI. For us, contract loading is a good example of such a problem because depending on your application, it can take days to enter the contract details into your system. We load thousands of them every year, so how do you approach it? You could, if you're small, you could give a chatbot a chatbot a simple contract and a claim, and it could actually price it correctly. But when you have hundreds of complex contracts, you need a system. So one step to get started, you might use an LLM to compare the current contract with an update, and it could generate a checklist of changes to streamline the work. You could go further by splitting that work into sections of a contract or service types that would appear in your checklist. And an LLM could be taught to understand each section. You take it one by one. Like in the last example, we could use agentic AI to walk through this checklist and generate data into your system for each section of the contract. You could test the result by pricing known claims. And then again, a feedback loop is important because it would help you continually improve your mispriced codes. So there's many ways to approach the problem, but it'll depend on your environment and skill sets. And I think the important thing is to get started, as Jonathan says. I hope you found that helpful.
Great, Michael, that was awesome. Yeah, so I think, reiterated on some of the things that Pinaki and I talked about there too, as well as dipping your toe in, making sure that you're doing your diligence, you're not creating hallucinations, you're starting small. Prime's example is they've started and really gone deep on the clinical side, and then they're dipping their toe into some of these other workflows. Those are two very common workflows, Michael. Thank you for sharing them with us. Everybody's got denials, even Pinaki. And everybody, I think, has contracts to load. Those are two very repetitive, stable workflows to start from as we go. Gen AI is here. We're going to talk through each one of these, and we'll probably go through them just a little quickly, just in the interest of time. But Michael, I'll probably lean on you a little bit as we go through here. But why you mentioned this? It's expensive to install, but on the human side, and you talked about high impact areas. But let's talk about like 1 and 3 a little bit. I think you can kind of couple those together. Maybe 1, 3, and 4 really. What is the human element of Gen AI? It is a investment. Why is it important? This replacing humans is a fear, but why is it important to think about these things, specifically 1, 2, and 4, as we're walking through AI in our organizations?
Well, I think Gen AI is a new thing. Yeah. Why it's different is it's non-deterministic. The answer isn't like 1 + 1 is 2. It can change. It can hallucinate. You have to put guardrails in place. We have what we call a trust and quality framework that has some guardrails on the input and the output from Gen AI. And then also we're always constantly evaluating that. Sometimes it's another LLM testing the answer of the first LLM, that sort of thing. And we monitor over time because just like the machine learning models, we have to figure out when we need to retrain them based on, data changes over time. Payers are paying at different times, or they're denying different types of claims, that sort of thing. So it's something that has to be continually evaluated, and people have to understand that difference. It's new, it's something very new, and it takes people a while to understand that this answer may not be correct. It's doing its best and it's supposed to help you along, but we still need the human to be there to agree or not agree. For example, prior authorization. We generate an answer based on the payer policy, and people have it's their own free will whether they go and get the prior auth or not, and we track whether they did or not and whether they were right or not based on the denial of the claim.
Great. Pinaki, I might lean on you here. There's these 4 areas that I think are very important. This is a great LinkedIn article, by the way. I put the link down there below. As Michael mentioned, Gen AI being relatively new, I'm using air quotes. This gentleman, Ben Carroll, did a great job on the first slide, and I think the second slide in terms of the text and content. But, Gen AI in terms of coding, billing, denials, patient financial experience, revenue cycle optimization, or platform, is there a favorite in there, Pinaki, that you would probably double click on or go in, or should you try to inflate all 4 tires on the car at the same time so you don't go in circles? Or what are your thoughts on these areas?
I think, given the fact that you had mentioned something around usability, timing, and aspects, those other slide that you had, that will be really dependent on how people utilize some of it. Personally, I focus on patient financial experience.
Yeah.
There's a lot of work to be done, and there is a bunch of different companies who are utilizing AI to come back and present it to us from a provider network perspective. So it's going to be a buy versus build conversation if you're a provider network. That's the first thing that I would say. The second thing that I would go into is really this predictive analytics for denials management. As a provider network, we have always had denials ever since we existed from a general perspective. And it's going to be there, utilizing Gen AI and its power from a perspective of utilizing predictive analytics is going to be key about how we look at it from a service department that the denials are coming in, the CARC and draw codes, obviously that exists as we have these conversations with our peer groups as well. I would say, I think I saw a question, since I have the floor, or answer it.
Sure.
I'm sure we're running out of time.
That's all right.
The case studies that we have in AI for RCM are going to be really dependent on who you're talking to, right?
Yeah.
So most of these provider networks that I'm talking to, most of my brethren from a fraternity of other facilities, we are looking at it and going, are we utilizing it ourselves? Are we going to build it ourselves? Or are we going to utilize it from somebody else building it? So that's a constant that is out there. As far as we are concerned, we have obviously held on the case that we talked about, and it's already in play. We have to sort of see how much of it we are utilizing it from a general perspective of doing it ourselves versus purchasing it from others. And as more provider network perspective, it will depend on exactly who the provider network is, whether they want to build it and be more technology driven or purchase it after it's completely vetted out.
It's a great answer.
Thanks,
yeah, I think you're going to hear this buy build discussion happening more, whether you partner. I've heard it's very rare to be one or the other, Pinaki, I think, to where you're all buy or all build. I've seen mostly hybrid environments. You've got someone getting the bots to you or the large language models to you from an infrastructure standpoint, but you might have your own in-house engineers that monitor that on a go forward. I was just at the Revenue Cycle Conference in San Antonio. I'll forward you the deck and anyone else would like to see. It was an excellent talk about AI and revenue cycle and how you deploy it and whether you buy or build. And as Michael mentioned, it's an expensive tool. And as it should be, it's saving you millions, if not hundreds of millions of dollars over time. So it's a wise investment, but I think you need expertise and you need internal controls, but having too much or one or the other, you can start to get into a little bit of trouble as you go forward. I think in the interest of time, we'll probably just jump to questions if that's okay. And Claire, if you're still out there, Pinaki and I and Michael are eager to answer whatever questions we might have in the remaining 11 minutes here or so. And Michael and Pinaki, thank you so much for your insights, but have at us. What questions do you have for us?
Yes, thank you, John, Michael, and Pinaki for a wonderful discussion. I'm going to go ahead and hop into some questions in the Q&A box. Audience, as a reminder, feel free to submit your questions via the box that you see on your screen. Let's go ahead and get started with our first audience question. Someone would like to know what opportunities are available for those interested in AI governance.
I'll start by what I heard at the conference, and then Pinaki, you probably have other governance committees at Prime, I imagine, that have representatives. One of our FinThrive advisory board members from a very large organization in the Southeast talked about his AI governance, and he's a CFO. And Pinaki, you were in the room and when Mike was talking, but he talked about having the chief technological officer, the CIO there first and foremost. I mean, this is a bright shiny object, a toy, if you will, that is birthed or genesis to the organization. And then he had the CMO there from a patient safety, medical care standpoint. The CFO, obviously, that's writing the checks, he or she. And then they had department heads that were involved, and they came up with policies and procedures. You don't want so much administrative burden out there to manage it, but you want to make sure that voices are heard, risks are assessed in a way to where you understand, like when a hallucination is there, how much of this is patient facing or not, I think is a good lens to look through. How much of it are you going to allow the the end user to have control of versus oversight by a clinician or an extender when you're in a care area. And then the revenue cycle side, those might be dollar thresholds. If there's $1 million plus claims, is that something that you want someone writing off through AI necessarily, or maybe there's more appellate rights that the system can't see? But Pinaki, do you have thoughts on governance? I think that's an excellent question.
I think it's a good question, and I think it's going to evolve as we move through. But
Yeah.
For sure, there are certain parties who absolutely have to have a table on the governance committee. Technology, CIO, CTO, CDO, and CISOs would obviously be involved, given the fact that it's a very delicate environment. Plus, at the same time, the CMOs plus the chief experience officer could be involved if they're doing some things around patient-facing aspects of it. The chief financial officers would obviously be involved from a perspective of how revenue cycle is impacted or how all of it sort of pulls in.
Great. I think, Claire, we can go to the next one.
Yeah, our next audience question was wondering if you could address some of the risks of AI as well.
Pinaki, do you want to start with that? I think you probably had some good things that you were talking about with Prime in terms of dipping your toe. Like, what are some risks you see?
To me, anything that you don't know, it's like walking into a dark room and trying to figure out how big the elephant is and which part of the elephant is. Right? Let's just be honest with it, right? I don't profess to be a person who's well-versed and knows AI in and out, but here's the reality of it. There is going to be risks involved. Personally and from a general perspective, we would stay away from anything which impacts directly patients' care. But the reality of it is there are aspects of it which are easier and should be able to sort of get into without having any impact to the patients, which are more so on the revenue cycle standpoint of it, more so on the recognition of information and collating of it. And then it gets into the information about when you're communicating with your peers. So that's how I would break it. And anything which has larger impact to it would come in a later bucket. Just part of sharing, and I don't think the question is related to the risk aspect of it, but I think even if you look at it from a general standpoint, I advise my team actively to use any tool that is out there from an AI perspective. They're using Copilot right now to make sure that their time is conserved about any transcription-related outputs, anything that they're coming out from a minutes of the meeting and following through with it. So it's really not just one shoe fit all. It's pick up the smallest item, look at it, utilize it, and go on to the next use case and start using it more and more.
Michael, do you have thoughts on risks, being an expert in the space as far as, I think you're starting small is probably a good idea. You don't want to boil an ocean and then have kind of uncontrolled chaos out there from an AI standpoint. But are there risks that folks should consider? I think that's a slide I'll have in the next deck that we do is AI risk, but what are your thoughts?
Yeah, that's really what I was saying before about Gen AI, the hallucinations. Even with a human review, it's still going to increase efficiency. Even if you don't have to manually enter things or go and look at a bunch of different data or documents to come up with a proposed solution or suggestion. And I think most of the time it's right in our use cases, so you can quickly go through, but a human should be there for anything that could get you in trouble.
Great.
It's okay to interpret a contract and then have some claims where you test the pricing before you ever release that contract and actually start using it. But when it's answering a customer's questions, for example, or writing up a denial appeal letter, for example, it's good to have that human review.
Sounds great. Claire, we'll take the next one, I think.
Yeah. Someone else would like to know how much effort will it take to interface AI with payers and reimbursement?
I'll start with that one, Pinaki, and then you could agree or disagree with me. I think it's going to be how well you're connected today would be the short answer. So I know, Epic's working with Payer Platform. I know FinThrive has some pretty deep analytics in terms of payer connections and integration with our Insurance Discover. And Michael, showed some workflows that we're innovating on in the future. And trust me, I saw the other list. There's 20 other things behind that are there. I think it's going to be how well you're connected today. And then I think you don't want payers to connect on everything either. I think I've heard horror stories, to Pinaki's point, of, having them have complete access to your medical record on the patients that are their members. And then they start reverse engineering, logic for denials or utilization management or medical necessity based off of care use utilization trends and those types of things. So it's a less is more thing. Specifically, I think things like eligibility, payment, denials, underpayments, medical necessity determinations, prior auths, those are all tennis balls, I like to call them, that are constantly being racketed back and forth. And whoever asked that question, you certainly could email me. We'll put our emails up here in a minute. There's about 17 times or 17 pieces of data that both the provider and the payer touch once on the same patient every encounter. 17 times it was measured. That's in my book as well. And those are the usual suspects: eligibility, the insurance plan, policy number, the discharge date, the CPT-4 codes, the HCPCS, those types of things. Pinaki, I don't know if you've got any deep integration with payers at Prime, but I would start with where you're at today. And I think it's going to be difficult if you've got nothing. And then I would be cautious in what you're connecting and relate it to those areas that I mentioned to start. But Pinaki, I don't have anything to add there. Or?
I think it's a broad stroked question, right? So I think I would answer it by saying, I would just add to what comments you made. It's really going to be dependent on who's connecting and what their appetite for connection is. And also from an appetite of investment is. It's a build versus divide discussion. If you think about it, you might want to break it up into a few pieces and saying an LLM, when it's broader, it's more investments, it's more longer from a general perspective of trying to sort of go back and create something that you have dependency on somebody else for. So breaking it down into smaller chunks and then sort of working with it is probably the good way to go. That's my personal opinion. The aspect of it is going to be really around what information you already have coming in with your clearinghouse. What information are you really leveraging out of it before you move into the AI space?
Excellent. Claire, probably one more, huh? You think?
Yes, I believe we have time for one more question here. So someone in our audience says, we received so many claim denials from our Medicare Advantage insurance companies. It's simply hard for our staff to address the incredible volume of denied claims. Can you please comment on the situation?
Yeah, I'll start with that one. I get this a lot. I know Pinaki probably does too. And here's the deal, guys. Denials is a 4-letter word now. You're going to hear it. Every conference I'm at, I hear denials as much as I hear the 2 letters AI now. And I'm starting to get into this eye roll. I'll get on my soapbox for a minute. No matter how much you scream, argue, broadcast, you hate denials. I worked for a payer. They're a part of doing business with a payer. Their job is to manage care. They're a managed care company, and they are going to introspectively inspect every single claim, every single charge, and pay it according to the contract in which you signed. Payers are not inappropriately denying things for the most part. They're denying them based off the information that was placed in front of them at the time. And then the overturn rates are like 80, 85% in most cases. And usually that's because that information wasn't there, or the payer couldn't see it, or there was a disagreement between your definition as a provider of medically necessary and the payer. My short answer to denials and the number is the only way you're going to throttle down or change altitude is through the contract. And I would argue you have to get analytics and some AI to understand what level or provisions of things within the contract are causing those denials. Things like the definition of medical necessity, as Michael was talking about, the definition of inpatient, the mutually exclusive language in terms of changing provisions within the contract. Like, do you get 24 hours or do you get 24 days? If you get 24 days, you can pretty much meet any auth requirement. If you get 24 hours, you can meet none. So those are my thoughts. Praveen or Pinaki, I don't know if you have any others, but denials, you're not going to play whack-a-mole and win, is what I like to say. You've got to take the hammer out of the payer's hands or the moles out of the ground, or whichever way you're looking at it, and try to fix it that way. And yeah, go ahead, Michael. Yeah,
I was just going to say, I will say we watch payer trends, and that is one where it would be great to have the bulk appeals solution so that you can send in a no-touch appeal in that case, and they will get paid. It's just a matter of recognizing that that's how that payer is behaving, and then figuring out what's the best strategy. And a no-touch appeal, sending it back. It's not always really a legitimate reason in that particular case. I hope
You
it's
bet.
okay to say.
You bet. Well, Pinaki and Michael and I want to keep the conversation going. I know this is a part of a series, so we're going to have in the widgets on there something you can click into to go look at that will allow you to participate in part 2 of the AI discussion in terms of denials. I'm glad that question came up last. It's a good segue. There's a QR code here as well where you can engage with us. Pinaki and Michael were also gracious enough, generous enough to put their emails on here. Mine is there as well. Watch out for those 2 I's and a K in my name. But you are welcome to email any one of us or all 3 of us if you have other questions. We'll go look at those questions after this is done. But I want to thank you all for joining us for this hour today and listening about AI of today and tomorrow. And Pinaki and Michael, thank you both so much for sharing the time with me as well. Your time was invaluable. And the rest of you have a great day, and thank you so much.
Thanks.
Yes, I just would like to thank John, Michael, and Pinaki one more time for such an excellent presentation, and I'd like to thank FinThrive for sponsoring today's webinar. Thank you again for joining us, and we hope everyone has a wonderful rest of your day.